When we go to the FCS workshops and I got somebody who can't do a standing long jump and they think I'm going to coach them on jumping, and we get the battling rope and we do a tsunami wave, a rope wave, that's two hands, just slam it on the ground and send a wave down to somebody else. They send it back. And we do about 6 of those, and I'm coaching somebody up saying, come on, and breathe. And we do this thing. The person comes back and has a personal best in their standing long jump. And they're like, oh, wait, I'm messed up. We were doing battling ropes. My jump just got better. And I'm like, well, if you look at what you did to do that jump, you went through every mechanic except your feet leaving the floor. So we played with the rope, got rid of a lot of parking brakes in your body. You come back, you're out of your head, you actually jump further. And so it's playing. I will always go from something somebody's getting too technical on, make them play with something else that's the same movement pattern, but they're not thinking about it, bring them right back. There's things we do in boot camp that test you. But what got you here won't keep you here. So we will test drive you every now and then. We will push you to that limit. But we don't have to do that every day, nor is it in your best interest. Now, there's a point where you got to prove yourself. But once you're on the other side of that, we spend way more time tuning race cars than we do racing race cars. And people don't get that. Race cars do not stress themselves every day. They stress themselves at competition, and they're tuned and tweaked every day in between there.
Like if I can clean up movement, I'm cleaning up metabolism. They're linked. They're completely linked, and it's I can't in my head separate strength. Like a lunge is a strength exercise if it's heavy, and pushing a sled is lunges for reps, which is less heavy, so it becomes cardio. And then running up a hill is this exact same pattern, and that's pure cardio. I just see the movement. If you didn't see the dumbbells, if you've seen the body, if you've seen the joint angles, then it just looks the same to me if I take everything else out, right?
If a lot of coaches really understood that the win of the FMS is getting it done, taking the screen, take the screen, keep doing it, and give it that power, because it is, those gold nuggets are in there. And the more and the deeper you walk into that assessment lane, the more you can start to understand the screens that come through it, whether it's SFMA for practitioners or FCS. Like, you are just building into that whole understanding your clients more.
The feedback's for you. What you do with it depends on who the client is, what the situation is, what the goal is, but the feedback's for you.
Yeah.
How much of that you share is pretty much like an airline pilot up in the front of the cockpit. He's not sharing every piece of information,
Hey,
just the stuff that makes you think he's competent.
I have a great steak at Maestro's, once every year, maybe for birthday or maybe for Sinley's birthday, but I never ask for recipes. I don't ask him. I don't go back to the kitchen and ask him how he cooks this.
This
and
is where the great steak is
I
found.
just enjoy the meal, baby. And if you can do that with your clients, and you don't have to discuss with them how you cook this and do this and all of these other things, and you just give them a great meal, I guarantee you, man, you'll be cooking for a long time in your life.
Yep. You and I have found the same thing. We've worked with the highest end people in the world. We found small, overlooked mobility and stability or general physical problems that were actually eroding their ability to do their thing. They're saying the exact same thing, and I think it's good. But here's what they said. We've got to do a couple of workouts to find those. All I ever said is, if I think somebody's a drunk driver, I'm going to administer test. We're not going to do a few laps around the block to see if you're too drunk to drive. Yeah. And that's the problem. If we've got somebody we suspect this with, it's getting too risky to even run those 2 exercise sessions.
Good afternoon, and thank you for joining us. Welcome to the FMS studios. Today, we're going to be having a conversation on the secret to reducing injuries. If you have any questions, please be sure to add them to the chat below. We have experts there, and we're going to be having an open Q&A at the end of the talk. If you enjoy today's conversation, we're sure you'll also enjoy the Movement Podcast, which Season 4 is actually premiering this Thursday, September 16th. Be sure to subscribe and never miss out on an episode. All right, that's enough for me. Let's get started. Dr. Lee Burton, co-founder of FMS, is going to get us going.
Thank you, Ashley. And I want to thank you all for joining us today on this topic, because this is a topic that all of us as professionals, we should be putting this at the forefront. Reducing injuries is tremendously important for all of us in this profession, whether you're a clinician, whether you're working with high-level athletes, or whether you're working with a 12-year-old looking to just improve his soccer game, or you're working with a weekend warrior. We've got to reduce injuries. And really, that's been a very, very tough thing to crack into over the last number of years, since we all been dealing with this as professionals. And here at FMS, we've been trying to deal with this for over 20 years with the inception of the functional movement screen. Now, when the functional movement screen was first designed, most people don't really know this. They just assume it was designed to figure out which corrective exercise I should be prescribing to the individual I'm working with. And that was not it at all. The colleagues that I work with, and actually one of them is on today with this, when we looked at this functional movement screen, it was really about bridging the gap between the pre-participation physicals and going into the weight room. And we were looking at more of the high school athlete, not worried about the professional athlete, not worried about what's going on in the military. We're just some guys in a small clinic in Virginia trying to look at that. And Gray walked in literally one day and said, hey, here's some movements we should be looking at after this person goes through the physical, or before they even see the doctor at the physical, to see, does the person have any pain? Do they have any major dysfunctions? And then from that point, if they've got pain or major dysfunctions, it wasn't about which corrective you're going to give them. It's about which exercise they should not do in the weight room. And that was our idea of really being more proactive in injury prevention. And I think early on when we started talking about the FMS movement screen and getting the functional movement screen out there to more people, we kept saying injury prevention. The functional movement screen should be part of that process. And I think that kind of took a life of its own, and quite honestly. But the goal was always really about making sure the person, and as we continued to grow, whether the person is a high school athlete or a soldier in the military or a weekend warrior, hey, let's make sure we are not putting them in position to get injured during their training. And I think that's very, very important concept. And over the years, there's just been a lot of research out there, a lot of information that's looked at the FMS tools. Now, before we get into that, let me just clarify this, and this is kind of on us for a little bit, because we call ourselves FMS. And most people look at FMS as the functional movement screen. Well, it's more than that. Functional movement systems is who we are. And that's a variety of tools and education, whether that's assessment, screens, tests. We look at the Y balance test. We look at the selective functional movement assessment. We have the fundamental capacity screen. And we have other pieces of information or tools that we've designed that really want to help whether you're a clinician or an exercise professional, help you get better outcomes. And that's what we're all searching for. And part of that is reducing injuries. So when we're talking about what we're going to focus on a little bit today is the research that is on the FMS systems, not just screen, because I think that's important as we frame up this conversation. And let's go beyond that. And that's one of the things we want to do. We want to go beyond just what we're looking at with our tools. But I've got two experts on here with me that are going to be talking about how do we really look at injury risk and making sure we reduce injury risk. Because let's be honest, I can't prevent a person from spraining their ankle if they're playing a basketball game. I can't prevent a person going out and, during a golf match from hitting a root like I do, because my ball's always up against the tree, and spraining my wrist. So prevention, but reducing risk. Prevention is tough, but reducing risk is really kind of the thing we're looking for. So that's really the conversation we're going to have today. And ultimately, how do we really frame up or give you some good advice based off of the research on what you can practically take away and apply to your clients, your patients, in your athletes. And that's very, very important. We want to make sure that, it's not just about what the smart guys and the white lab coach tell us about. We got to give you some practical advice. So I've got those smart guys, the guys who, in my opinion, are experts in this area as it relates to injury research and injury risk. And again, they've done a lot of research in this area. They've published a lot of papers in this area, so I think it's really, really important to bring them into this conversation because obviously, listen, I'm biased. I'm functional movement systems. And certainly based off the research, we're going to be a little biased, but that's because that's what the research has told us. And I think that's what we want to do. And again, I think we got to get towards the end, get a little bit broader and talk about musculoskeletal health. How can we take this information that the research is telling us and what we've been doing and apply it and get a little bit broader because we've got to be doing stuff differently. What has been happening over the past 20, 30 years is we're not having a major impact with all this information, all this research that we've been reading and doing. Have we had a major impact as it relates to injury reduction and as it relates to overall musculoskeletal disorders? So we're going to talk about that. So first, I'm going to introduce the two guys I got with me, and I've known these two guys for a long time. Dr. Kyle Keysel, the first person who I've worked with, basically he brought me up from a pup. I graduated from graduate school, and one of the first people I worked with obviously was Gray Cook, but also Kyle Keysel. And I don't say this a lot, but Kyle was a mentor to me early in my career. When I thought I knew what I was doing, Kyle was one of those guys that kind of pat me on the back and said, "Nah, we need to take this approach, and here's really what you need to be thinking about." So, it's definitely was eye-opening coming in and learning so much different ways of doing stuff. And as an athletic trainer, coming out of graduate school, I wasn't proactive. I was always reactive in how I'm thinking. And working with Kyle and Gray early on made me think a little bit differently. So Dr. Kyle Keysel, who's a professor emeritus, I can't believe I have to say that, but that's what he is, and a former chair of the physical therapy department at the University of Evansville. And he previously practiced orthopedic care pro rehab in Evansville, Indiana. But Kyle got to start working with Gray and myself in a little town in Danville, Virginia. The other person we're going to have on who's done a ton of research and got to know him, known him probably 15, 16 years now, is Dr. Phil Plisky. He's an associate professor of physical therapy and director of the residency programs at the University of Evansville. He also serves as a consultant for collegiate and professional sports teams, as well as works with the military forces to help transform their performance and injury prevention systems. So two guys right here who have done a ton of research, not just on the tools I mentioned about FMS, but just injury prevention in general, and that's what we want to talk about. So the first thing I'm going to get Kyle to do is really give us a little historical perspective and what the research says as it relates to functional movement screen, but also the other tools, Y balance. And Dr. Plisky is the inventor of the Y balance test, so obviously he can speak to that. But Kyle, kind of give us that summation of kind of where we were with the movement screen and how it transitioned and where the research is saying today about that and how that relates to injuries.
Sure, Lee. Thanks for the opportunity to share this. Let's go back. As you mentioned, the movement screen was designed to help us get people from physicals into the weight room, hopefully without getting hurt. And we started in the high schools, and it got some traction. And we fast forward, and all of a sudden, it's in professional sports, and particularly in the NFL. And I was working closely with one of the strength coaches in the NFL, and he said, "Hey, listen, I've been collecting this little test you guys showed us for 3 years. Let's take a look and tell me what's going on with this." And what we found was this retrospective little pattern or little signal of doing poorly on the FMS and being hurt like on injury reserve, major injuries. And that evolved into the first study that was published on the FMS in injury, a little retrospective pilot study that just looked at FMS and the association with being injured. And so that got the ball rolling. And at that point, you can go read that study today, and it says, listen, there's maybe something here we need to consider into our injury models. And things have evolved from there. We started working closely in the military, and there were larger and larger studies looking at multiple factors. But really, when Phil and I connected in Evansville, we said, listen, there's never going to be one tool that's perfect for injury prevention and prediction. So we certainly understood the research was clear that it's multifactorial. So we started adding different pieces like previous injury, for example, and started to bring different risk factors together. And that evolved into large military studies where we looked at multiple factors, et cetera. At the time we were going down this path of multiple factors and combining things, the world got a hold of the FMS, and the message got out that if you score low on the FMS, you're going to get hurt. And good or bad, that's where we are today. And there were literally hundreds of injury risk studies looking at one tool, FMS, does it predict injuries? And some showed it did a little bit, some showed it didn't as much as maybe we thought in the beginning. Fast forward right now, today on PubMed, you can get 5 or maybe even 6, I believe, systematic reviews helping you answer that question. Is there any signal in the FMS relative to injury risk, or does it actually predict injuries? One tool. And we're like, well, that's nice, and we'll share that with you. But it's always multifactorial, and we took it from there. So, in a minute or two, that's just a brief background of sort of how we got to where we are today. And I guess if there's any take home, the FMS does have some predictive validity for injury risk, but we always recommend combining risk factors for your best opportunity to identify those at greatest risk.
Yeah, so let's dive into that a little bit. So Kyle, when you say 2 things you said there, let's clarify a little bit. And the word risk factor. What is a risk factor? And when we say, most people think of risk factors as it relates to general health, cardiovascular disease. What are the risk factors? And I'm sure most of your patients, clients, and athletes we work with, when you say, hey, how do you avoid, having a heart attack? They could probably give us a few things. Hey, don't smoke, exercise and eat right. So when you talk about risk factors, Kyle, give us a little bit more insight of what you're talking about.
Yeah, so there's different definitions, and you can utilize the term risk factor in slightly different ways. But if you're looking at, let's just say globally, musculoskeletal health, what are the attributes or characteristics that have some validity or some association with developing a disease or a problem or an injury? So in musculoskeletal health, we're talking really about developing a musculoskeletal health problem. What are the factors that we know are associated with that? And so we do individual studies through a very detailed methodology to determine if a subject has these factors before. We follow them out for 12 months and we see who develops the disease or the injury, and then statistically associate what we found in the beginning with what actually happened in the end. So it goes through a research mixer blender, if you will. And then when it's a validated factor showing that it does have independent association with injury, then we would consider that a risk factor.
Yeah, so if you take something that, that everybody knows, smoking, I don't think there's anywhere around the world people don't realize smoking is bad. And that's because smoking, as you just said, went through that whole process over the, probably in the 40s and 50s when everybody was smoking pretty much. And they realized that this is a risk factor that consistently is shown to create health problems. So Phil, I want to kick it over to you. Kind of right now with the Y balance test. I mean, what is, as Kyle said, you guys came together. When you came together and you started saying, hey, the Y balance test and the FMS, Kyle mentioned multifactorial. So I'm going to ask you a couple of questions. One about the Y balance test research, and also the SFMA research. I know there's more and more research on the SFMS, but also this idea of multifactorial. What does that mean?
The key thing, if you look at the systematic reviews on the Y balance test or star excursion balance test, it again probably almost mirrors a little bit of what the FMS looks like. There's some studies that say it's absolutely a risk factor, it's without a doubt, and then there's some studies who don't look at population specific cut points and norms that say it's not a risk factor. But when you combine it with previous injury, with movement, with pain with movement, it becomes a very robust risk factor when you categorize people according to multiple things. It's not just one thing.
So what are some of these risk factors that you guys have found? And I think you said an important thing there is also population specific. Obviously me right now, I do a little bit. I work out. I kind of, I'm working out a few days a week. I like playing golf. I do other things, but I'm not out there running a Spartan race next week. I'm not out there playing football or I played basketball a few years ago. Realized I don't need to be playing basketball anymore. So my population where I am, I'm not putting myself at risk like a person who is an 18-year-old playing Division I football. They're at much higher risk, and it's due to their practice and all that. So maybe Kyle or Phil, I'll throw it back to you. Phil, speak to that population specific and kind of that process and some of the risk factors that you guys have found based off all the research you guys have done.
Yeah, absolutely. Well, population specifics are really important for the reasons that you say of, yes, whether I'm putting myself at risk, but it's also important because we know that certain populations have they adapt their balance, for example, differently. Soccer players have better balance in general than basketball players, and that makes a lot of sense. They spend a lot of time in single leg stance. So we have to consider what someone should score for a population. In addition, we need to look at, for example, our military studies. We scoured the literature of what risk factors have been shown, and then we threw them all together and said, all right, let's test them all and then follow people out. And the risk factors that keep coming up at study after study: previous injury, pain with movement, balance asymmetry on the upper quarter, lower quarter Y balance test, that dynamic balance when you're getting to the extremes of motion, whether you have something as simple as, do you have ankle dorsiflexion symmetry? If you have a 5-degree closed chain difference side to side, that's a risk factor. And then one of the most interesting ones to me is if someone's had an injury, asking them, how well do you feel that you've recovered on a 0 to 100 scale? And if you haven't recovered to above 92.5%, you're more likely to get injured. And then you get into the general risk factors of high body mass index and cardiovascular fitness, your aerobic capacity, and asymmetries are really important as well.
So Kyle, if you leave those up as an example, the ones that Phil just mentioned, kind of walk us through what you mean by multifactorial. And I think you said it and I think Phil had mentioned too, in order to be even in the study you mentioned, Phil, you had to already be known as a risk factor. And I think, Kyle, you said independent in and of itself. So what does that mean? And then kind of using those 10 or so risk factors, kind of walk us through what you mean by multifactorial.
Yeah, for sure. It's a crucial topic that people understand it. I think when most injury risk studies are one-off small projects that someone's trying to prove X relates to Y, and those are good. We need those. But when you put things together into a program that's going to work for you, you have to look at things in some kind of summation. So each one of these factors is independent when we do the studies. So when we have a study that shows 7 factors were related to injury, it's not that those 2 things are related. Each one independently contributes. So that's one piece. That's just a statistical test that we run to be sure that each of the factors are independent of each other. Having said that, when one individual possesses multiple independent risk factors, their risk goes up. Okay, so let me just say that again. Each risk factor is independent of each other, meaning if I have just one risk factor, I'm at risk. If I have one of the other risk factors and not that one, I'm at risk. But when I stack together multiple risk factors, my risk for injury goes up. So when we're trying to identify who's at greatest risk, and there's a lot of value in doing that in some populations, because I know in sports medicine professionals just don't have the resources to work with everybody one-on-one. But if we could screen out those at the greatest risk, those that possess multiple known risk factors for their population, maybe those people we could do some mitigation strategies with and see some changes. So multiple risk factors, when they stack, increases risk, and we've shown that in several studies. So that is something that I can't stress enough, the importance of that, and understanding that from a broad programming perspective when you're using this information in whatever environment you're in.
So basically, taking that, what we're talking about here, no different than health risk factors. If we talk about smoking and drinking too much alcohol or not eating right and not exercising. If I'm exercising, I'm not smoking, but I have a little bit of alcohol, describing myself, then I don't have as many risk factors. So my health risk factors are a little bit lower. So ankle mobility being bad, previous injury, pain with movement, and I've got a high BMI. Well, that's risk factors I've stacked on top of each other. And I think Kyle or Phil speak to, what you guys did in one of the studies is you started creating categories. And I think that's what's important. And that is, to me, that's kind of one of the practical takeaways when I read some of that information is, independently, most people have probably one of those things you just listed up there. If they're going to walk in, well, obviously in the clinical setting, they're already in pain. But even in the fitness world, strength and conditioning world, a lot of them have already been injured. But we start stacking these up. When you start stacking those together and combining those, now we can get somewhere with that. Is that right? And Kyle, we were talking about that with your resources conversation.
Yeah, for sure. So really what we're getting at there is what we took this concept of multiple factors and we wrote an algorithm to say, if you have X, Y, and Z, you're in pretty big trouble. We're going to put you in the highest risk category. So we created an algorithm based on this research called the Move to Perform algorithm. We then tested that in a study, validated that in an independent study like we would do anything, and showed that if you're in the high risk categories, you're 3.4 times more likely to have an overuse injury. So what category you're in just took the factors and stacked them together. So example, you have a poor functional movement screen. You have no zeros, but maybe you have a score of a 13. So that means you got to have a 1 in there if my math is right. Okay. Well, if you've never had a previous injury and your ankle's okay, and your BMI is normal, and you can jump and run and cut and don't have major strength problems, your risk is low. Okay. But if you have a 13, that same 13, and one of your problems is an ankle, and you were hurt in the last 6 months and your BMI is a little high, then you are a glaring injury getting ready to happen. So the FMS is helpful. It's one filter, but it doesn't tell the whole story. You have to put them together. And that's why we created the algorithm, to just make that easier for you out in the field to do that.
I think it's really, if I can add on to that, I think it's really important for people because our original research looked at a total score on the FMS. And that's an okay thing to look at, when you say it's got to be above 14, and that is important. But like Kyle mentioned, how you get that 14 is really important, and what other factors you have. For example, really pain with movement, so a 0 on the functional movement screen, is the equivalent of smoking for all other cardiovascular risk factors. So pain with movement is kind of a card that just really negates all the other risk factors in that you are going to have a problem if you have pain with movement. And some would argue you already have a problem. And so it's looking at, okay, if you don't have pain with movement, but you have these 5 other risk factors, now that's when we're going to have a problem. So be careful just to not look at the total score, but how the score is made up, and more importantly, how it relates to other risk factors and how many there are there.
So when you guys, based off the risk factors you identified, let's be honest, we're talking about the functional movement screen. That's when you say pain with movement, that's where they're identifying. Correct me if I'm wrong. And then when you say dynamic balance, ankle mobility, they were using our tools to identify those things. Is that right?
Yes, that's correct. Partly though, it is really pain with any movement. Even in our large military study, if you had pain with a triple hop, for example, that was a factor as well. So, now by far and away, pain with movement is in the functional movement screen. That's where it occurred most. But just note, for everybody, it's really important to understand that pain really is a huge risk factor, and you can't just say, oh, I know they have low back pain, it's okay. It's a risk factor. Even if we can't get it away, or when we try, we still have to acknowledge it.
Let me just add to that if I can, and not to get in the statistical weeds, but we had these large samples, and one large sample we only looked at pain with movement, so reported pain with movement and previous injury. We put those two together, and the risk of injury was almost 2.5 times, just those two things. Okay. So the idea that pain with movement is something that you're going to accept and roll the dice on, we believe would be a mistake. So pain with movement, we then followed that population for 12 months and tracked who had a true time loss injury. We didn't pull them out and say they were hurt. We let them go into their environment for 12 months, and statistically, the models told us you're more likely to have a true time loss injury if you have pain with movement up front. So that's a distincting factor for you.
So guys, help me make this transition here to what we're talking about. And I think what most people maybe have a misconception about injuries in general. And I think most people assume people get injured playing a sport, working out. I mean, there's research saying that exercise is a problem right now anyway. So you got all these risk factors, and then you get this idea of pain and musculoskeletal disorders. I mean, I think, Phil, maybe you talking about low back pain. A lot of people have low back pain. It's a huge contributor to time loss at work. And then the leading contributor, leading cost right now for insurance companies is musculoskeletal disorders. So musculoskeletal disorders are a major, major issue right now. And I think we need to take the information that we've gleaned over the last 15 years. You guys have been doing this with the research. How do we apply some of this to try to positively impact musculoskeletal disorders and improve someone's musculoskeletal health? I think ultimately that's what we need to be doing. Let's be honest, there are not a lot of professional athletes out there. Most people might be playing their sport on the weekend, but they just want to feel better, and they want to feel better long term. My goal right now is not what my goal was when I was 25. I want to be able to go out, play golf when I'm 75 years old, and play with my grandkids without pain or major dysfunctions or problems. And I think if you ask most people around the world, that's what we all want. How do we get to that point? It's not easy, but I think we've got a little recipe here. Knowing what we know now, let's try to talk about that a little bit. So the first thing we need to do, in my opinion, is define musculoskeletal health. And I'll kick that to Kyle first. But Phil, I want to get your opinion on this too.
Yeah, Lee, there's a lot to unpack there. Just musculoskeletal health by definition, pretty straightforward. It's muscles, bones, and the nervous system to produce movement, so you can go do what you want to do, basically. I mean, that's simply what it is. There's about 150 different medical diagnoses that can adversely affect musculoskeletal health. So it is a large group of medical diagnoses when we say musculoskeletal health. And of course, back pain, neck pain are very high on the list, but keep that in mind. And then I just want to share kind of this picture that we're seeing in MSK, and it looked very similar to the picture we saw with sports injury. We started out with sports injuries, and we saw that this movement piece might matter, and then we saw if we add multiple factors together, our ability to predict injuries gets more narrow, gets more precise. And we're like, okay, this is helpful. We have an algorithm. We've been down that path. It is the same picture in musculoskeletal health. I kind of moved my research and efforts to looking at general population, and I'm seeing the same thing. All of a sudden, people are saying, well, associated with low back pain are behavioral health problems like depression and obesity, body mass index, and same song, different verse, things are multifactorial. And so our musculoskeletal health efforts now, mirroring what we learned in sports, is looking at general population, multiple attributes to MSK, figure out what the biggest problem is and work on that first. So keep that in mind. And we were able we're mirroring this sports injury process for musculoskeletal health in general.
Yeah, absolutely. I would just have to agree that, musculoskeletal health to me is the ability to do what I want in an unrestricted fashion. And I think, like you say, whether that's playing with grandkids or competing at the highest level of sport or in the military, being able to do my specific job, that's what musculoskeletal health means to me.
Yeah, and right now, based off of some of the statistics I just mentioned, I think we all understand that as professionals, and I'm sure that's primarily who's watching this today, there is a problem and there's no easy solution. And I think the thing that we've uncovered is that this idea of having these multiple factors, if you're going to try to improve yourself, you've got to look at these things. And again, throwing those slides up there, chronic disability, it's the number one medical cost, and 1 out of 3 seeking medical care from musculoskeletal disorders. 50% of the U.S. population has these issues. And again, in my opinion, because it's starting to get in everyone's wallets, the insurance companies, our wallets, it's going to be paid attention to much, much more. And the solution isn't just go start an exercise program. I know that's what we would like to think, but based off some of the data and the research, these two doctors have explained, it's much more complicated than that we can't simply say, go out and eat better, go out and, start walking, that, we've got to consider a lot of these things, Phil, and some of those things go beyond, some of the tools and some of the things we provide.
Oh, absolutely. I think it's very simplistic to say, oh, go ahead and exercise, when now exercise is becoming one of the biggest risk factors for musculoskeletal injury, is just starting exercise programs. And we've all seen it. It's hard to exercise a lot of times for people to get the motivation to do it. Well, then you add, after a couple of weeks, now I'm injured and now I have pain. Now we kind of start this downward cycle. So it is important to consider, if we consider movement first, and look at those things, even as we start or prior to starting an exercise program, that becomes essential. We've got to look at that. Then this is looking at the person as a whole. We've got to look at, how well are you sleeping? What's your nutrition like? What's your hydration status like? What is your relationship status? Meaning, do you have good connections in the community or with others? All of those things go into musculoskeletal health. They all play a part in that. So we've got to look a lot more comprehensively and a lot more globally.
Yeah, and Kyle, one thing Phil mentioned a lot of things there: lifestyle, behavior factors, and I think Kyle, the thing you mentioned is too often we work in silos. As professionals, we just gravitate to the one thing we're good at. I like doing the movement screen and I'm only going to do corrective exercise. The movement screen is all I'm going to do. Well, we can't do that anymore if we're really going to try to solve this problem.
Yeah, let's take it to the medical world first before we look at rehabilitationists or fitness professionals. Medical world's very guilty of the same thing, right? So you go to exercise, you hurt your back, you go see the back doctor gives you things to do, but doesn't do anything else with you, just deals with the back. And then your shoulder hurts and they got to bounce you over to the shoulder person and they're going to do shoulder stuff. And every medical professional puts a microscope on your problem through their specialty lens. And all of a sudden you got 4 orthopedic doctors looking at you and no one knows who you are, right? Can't make this up. Happened yesterday talking to my mother-in-law. She was in with her doctor for knee pain. She said, my hip hurts. He said, I don't do hips. I'm like, okay, so when we have somebody in rehab or we have somebody in training in whatever environment you're in, we've got to be able to look at the factors that Dr. Plisky just laid out in some logical way. And I just say this with passion, not everybody needs every sleep app that's out there. Not everybody needs mindfulness and meditation. But if it's the number one thing you need, it is going to really help you a lot, right? So figure out, we need a model to figure out what everyone needs, where they can start. Because when you find your biggest problem, or many of you hear Gray Cook talk a lot, he'll call it the bottleneck. When we find your bottleneck and you work on that, lots of other things start to get better, okay? So again, it mirrors what we learned in sports. We're seeing it in musculoskeletal health, and we're just trying to promote tools and education to be part of that solution.
And that's one thing we're doing here at FMS, taking all this information and trying to, and again, one of the things we do is move to perform. Move to perform will allow you, especially in the discharge, if you've been injured, using that to place you in a category to know what risk of injury you're at, even if you're being discharged. And we feel like we have the same opportunity to do that in the musculoskeletal health world, to start stacking up these risk factors that we know. And as Kyle said, we have to prioritize. Sometimes the priority is not necessarily going out and exercising. The priority may be that you got to get your sleep right. The priority may be you got to get your mind right and some of those things. But I don't want to sound like exercise is not part of the solution. It certainly is, but it has to be done correctly and dosed right. So let's talk specifically, guys, about what are some of the practical takeaways. Kyle, let's talk about. Let's start talking about the medical area and how we want to provide some solutions. So when people walk away here, it's not just talking about research, but here's some practical takeaways.
Yeah, it just depends on your environment, right? I mean, what I feel I'm probably most versed in is helping a musculoskeletal rehab provider improve their care. Like, it's what we do. We train people around the world. So in that scenario, I would think about what's an appropriate discharge test or discharge goals for your patient as they get over their knee pain, their back pain, whatever it is. Well, hopefully I've screened for nutrition, sleep, behavioral health, okay, and I'm managing that. And if there's a big problem, I'm going to refer that person out. If it gets better, great. And then at discharge, right in my musculoskeletal health world, I'm going to be sure to utilize appropriate tools. For most patients, that could be as simple as some balance testing. We certainly have good data on balance testing. For people that are a little higher level, the functional movement screen, no zeros, no ones. That wipes out a lot of those risk factors. So I think depending on the lens and how you look at it, and again, I'm not telling you how to treat your patients. I'm just saying, shouldn't we all have some sort of similar goal at the end to say, hey, I've reduced, or I've got the ability now to track and manage risk factors. Some of these factors aren't going to go away, but if I can manage them and I can educate patients that this is an ongoing thing, I can't just discharge you. Here are your exercises. Keep doing them for a while and good luck. That is really what happens a lot of times today. We can do much better than that by measuring and managing these risk factors. And certainly all the work that Phil has done in discharge testing, he has algorithms to help you do that. But I think, again, key thing is discharge. And just one other study that we took the military group and we said, all right, previous injury was a big problem. So we took 500 soldiers, and at discharge from rehabilitation, it was back pain and knee pain primarily. We did all of our tests, okay? And then we followed them out for 12 months. So they got discharged from rehab. Their back pain was better. Their knee pain was better. They're going back to full duty. We did all our tests. Long story short, there's a lot of data coming out about this, but what we found was almost half, 44% of these soldiers still had pain with movement, with basic movement. And there was obviously other risk factors that were there as well. So we're not making it up. We're studying it. We're doing the best we can. But if you're a rehab provider, if there's anything you can do, create some standardized discharge testing in your facility and find a way to track people over time to manage these risk factors.
And Phil, you have some of those. You have some like a standardized protocol or process that you go through that you recommend?
Absolutely. We've kind of broken it up to make it a little bit easier, that if someone has a lower body injury versus, a spine injury versus an upper body injury, just trying to understand what tests do I need to do based on their level, based on their functional level. Meaning, if I want to get back to, gardening and that type of thing, there's not a person I don't think that's hardly not appropriate for balance testing, particularly dynamic balance testing. There's several studies doing balance testing, particularly the Y balance test after total hip replacement, or in 80-year-olds who have low vision, or people in assisted living facilities. But I don't think we're looking, like Kyle said, we're not looking in a standardized manner. So yeah, you can download those checklists. I think we have one of them here for the viewers. They can download that, get an idea of what you should be doing, because honestly, it's what I need. That checklist is what I need to kind of keep myself on track to be sure I'm doing the right thing. This is a great opportunity for fitness professionals and healthcare professionals to really take a look at the whole person and manage risk factors rather than just looking at the isolated knee, like Kyle said. Let's look at the whole person and understand what's going on with that person so that we can long-term improve their health and also make a long-term relationship with our clients. Meaning, I don't want to see someone just once for one thing. I think we need to get away from the idea that, we heal people and they never get injured again. I mean, that's life. Life is about kind of getting injured and having pain and things like that. We naturally deteriorate. So we need this consistent process to check the person and say, hey, how are you doing? What's going on? And we can do that very, very easily with just the simple screening in fitness. And if we really can make that, all the fitness providers out there, if we look at that, how many people come to you with pain, right? Or come to you after not having their pain resolved? What do we say to them? Well, no, you can't do any fitness until you get your pain resolved. They're like, well, I've been in medical and it didn't. Well, screening helps us know what not to do. Like you led off with, Lee, like we can know what not to do by screening. So if a lunge is painful, we're going to avoid that pattern, but that gives us tons of other stuff to work on and improve their fitness, improve their other risk factors.
Well, that's one thing. That's been a goal of us from the start, Kyle, is trying to kind of create this communication between the medical professionals and the fitness and strength conditioning professionals, and trying to make sure that we're continuing to kind of refer back and forth, knowing right now, based on the research that you guys just mentioned, knowing there's a lot of people that are being discharged that have multiple factors for injury. Then they're going to walk right across the street into a gym and go see a fitness professional that, at the end of the day, they're not equipped to handle someone who's in pain. That's not their job. Their job is to take someone who is coming in that wants to continue to get better. And let's talk real quick about that person who walks in to the fitness or strength conditioning professional that's ready to work out. What are the steps they need to take? And Phil, you alluded to it, so I'll let you kind of carry on with that a little bit. Start with the screening. Start with, again, I think too often people assume, at least I do a lot of times, assume some of these other professionals are doing certain things and they're not. So what are those checklists for the fitness or strength conditioning professional?
Absolutely. What's really cool, and I think, we talk about communication between professionals, as we refer to each other, that's the best relationships I've had. That's the best outcomes for my clients and my patients. But this discharge testing checklist really actually is where the two professions actually meet. Because if you look at the lower extremity one or the lower body one that we have here for you, you'll see that, yes, it includes things like the functional movement screen and Y balance test, but it also includes hopping and performance testing that we see in the fundamental capacity screen, so that we know what that person's performance problems are from a physical perspective. So we really want that person. It starts with a very simple intake of, hey, where are you having pain? Have you had an injury? And how recovered do you feel from that injury? And then let's look at the functional movement screen, and let's look at the motor control screen, which is a derivation of the Y balance test, and get a quick snapshot of where that person is. And if then we want to program their fitness, we're going to look at the fundamental capacity screen. It's going to dial us in really quickly on what we need to do. But yeah, really just, we said it early in the program here. Pain with movement is such a risk factor and so prevalent that if you don't know that as a fitness professional or strength and conditioning professional, if you don't know that someone has pain with movement and they haven't told you, that's where I think a lot of harm can actually come, and where people drop off as clients because something's hurting, or they make something worse from an exercise, not from doing too much. It's just maybe doing the wrong thing.
And Kyle, the one thing you mentioned, kind of transitioning from the injury side to the musculoskeletal health side, is all the behavioral and lifestyle things we got to consider. And again, we got to get out of the silo aspect. And I think that's where this idea of screening is so important. You're not diving into the details. You're just trying to get a quick snapshot of where you need to focus, right?
Yeah, and that's a great point. When we look at these multiple dimensions, and we track them quite closely here, and we have models to do this, we simply screen for sleep. We have a 4 or 5 question sleep screen. And if you score a little low, we're going to give you a sleep questionnaire. And if you don't get better in a couple of weeks, we're going to refer you for a sleep specialist. We're not specialists in that. We give you some tips. If it works, great. If it doesn't, we're going to refer you out. And we do that with everything. We screen for nutrition. We check your knowledge on nutrition. We talk about how many Mountain Dews a day are you drinking versus water. Some very fundamental things. Have you been screened for allergies? So we just touch nutrition. We touch behavioral health. Okay. So when there's a problem, we dig in. If it's getting better and things look good, then we're going to move on from there. So we do have tools. We can touch each one. Again, remember, we're always looking for that, whatever analogy you like, the blinking light, the bottleneck, your biggest problem, low-hanging fruit. We can throw lots of analogies at you, but we're looking for that person's biggest problem today. We're going to work on that, give them some advice, and from there build smart programs to get them where they want to go in a healthy way while we're managing risk.
So let me just, a couple more topics here, and we'll take some questions or just some things I want to get you guys to comment on. Obviously, I'm sitting here with my FMS shirt on. We're at Functional Movement Systems, and we're talking about our tools. But a lot of people out there, they may like another movement screen. They may like some other things. And I think the common question we get is, well, Lee, I don't have time to do all 7 tests. I only do maybe the overhead squat, or, Phil, we mentioned balance, and maybe I only do this or only do that. Let's kind of break that down a little bit. I mean, give me both of your opinions on maybe some other movement screens that are out there, and really things they need to consider. Obviously, obviously I want you to do the FMS for all the reasons I know and the data that we have and the research, but that's okay if you're not. At least look at movement, at least consider pain and what that does. But some of the things you may not be capturing, kind of speak to that, guys, a little bit.
I think, to me, one of the best examples is, there's some research in the ACL literature that says, your landing mechanics, if you're going into a valgus collapse position, that may be associated with ACL tear. And again, I'll apply the same, litmus test that is applied to the FMS. I think as a one-off risk factor, it's okay. I mean, it should be used as part of a multifactorial, algorithm. But what you do when you say, oh, I just look at landing mechanics and I look at the deep squat, well, you may miss a lot of things that could be causing the landing mechanics to be bad. Yes, they may have a bad skill of jumping where they don't know how to jump and land correctly, or they may have a hip impingement problem or an ankle impingement problem or poor core stability or motor control at the hip. And when you kind of pick and choose, cherry pick from, different screens, you don't maybe realize all the interplay. I look at the inline lunge, for example, is a great example to me. People look at that and go, oh, yes, I love the inline lunge for its lower body, what it does, tells you about the lower body. And, you could actually say the inline lunge probably has as much upper body involvement and balance involvement and, as it does lower body. So if you delete that out, suddenly you might miss, oh, wait a second, we're looking at the abductors and adductors in a stretched and shortened position all at the same time, with balance, with ankle, with shoulder mobility and thoracic mobility. Whoa, there's a lot more than maybe meets the eye. Same thing is simple on shoulder mobility. Oh, well, I don't need shoulder mobility because shoulder's not important in my athlete. Well, no, we're going to look at T-spine mobility with that as well, and how well all the things interplay. So,
yeah, if I may, I agree, Phil. And I think when you're looking at other screens, no problem. Obviously, number one, if there's pain with the screen, that's a problem, no matter whose screen it is. I think just from a research perspective, not to kill you the whole day with this, but has the tool been vetted for reliability? So that's number one. If someone does it over and over and over, they're going to get the same score, and that's important. And then two, what's the validation of the tool? What does it mean relative to that tool? So if you're talking injuries, has that tool been vetted in a validation injury risk study that's prospective in nature? So those are the two things to think through from a research perspective. But just practically, our experience looking at other movement tools, there's a lot of them out there, and they're slick, they're cool apps to work with. In general, my opinion, they tend to overdo things from a biomechanical perspective. They're like kinesiology screens more than movement screens. I think movement we think of movement more as a behavior, and it can be captured in certain ways, not a sum of kinesiological things that happen at each joint. So if you're using a movement screening tool that gives you a list of numbers of something that happens at each joint, I just not sure it's time for that up front. That you might need that at a different point, but that may be in the weeds and look really neat, but you've got all this information and we're really not sure what to do with it. When you look at what we're talking about here, we're saying no zeros, no ones on the FMS. That's just saying a lot. We just captured all kinds of information there. And then we get linear, we get down to the 0.5 centimeter on the Y balance test, but it's still out near your limits of stability, not telling me that I've got, 22 degrees limitation in my shoulder. That information, when you're going into fitness or into sport, really, it's a level of information that just doesn't help me make a decision, I guess.
Kyle, that's a great point you just made there at the end. I mean, you made a lot of great points. I won't cut you any slack, but
thanks.
that one at the end is practically, how do you apply this information? How do I apply the information I just captured? And if we try to make the screen as quick and as easy as possible to give you better decision-making processing, to give you better information on what to do next. And I think that's why pain with movement is the number one thing. If it hurts, and we're taking you through multiple movements, it's not just overhead squat, it's not just the lunge. We're looking at a multitude of different things. And does it hurt? And based off the data and research, one of the things we added in over the last few years, and you guys were a big part of that, and really, we're spearheading this process, was adding in the ankle mobility to the functional movement screen. And having that added in was based off some of the data and research. So I think that's a very, very important thing. And just to kind of summarize here and take some questions, I think that the big takeaway is there is some practical approaches to this. We start off, what's the secret? And that title was chosen not by me, but it was chosen because it is a tough thing to understand. And I think the big takeaway is understanding that there is some things we can do practically. Looking at the factors that we know that are research and evidence-based, balance, pain with movement, these things that we've identified, stacking those together, to me, that's the secret. It's not the one-off thing that we can just say, okay, I'm only doing this, or I'm only going to look at this. You got to look at all these and see how many does a person have in front of you. Then you've got to make a decision. And that decision being made is then based off other factors. What are some of those other factors? Well, the population that they're in, what is their goals, and then bringing the other. And then also, if we're talking about musculoskeletal health, all the other behavioral lifestyle things we have to consider. But it's considering all the things that we know right now based off the research, stacking those up to help you make a better decision. That's really the goal of what we were trying to get across today. But you got to do that based off what the evidence and the research has said. And we did a little summary today of that. So I want to, these guys will stick around. We're going to get Ashley to feed us some questions. And if they're really hard questions, I got two guys here that can probably answer them.
All right, Lee, and thanks so much, guys, for having this great talk with us. We do have some questions. I wanted to say hi to some of the people in the chat. We've got Johnny, Michelle, Tracy. We've got some questions from her, Maria, all some great questions. And thank you to Michelle and Brandon taking some of those on as well. So we've got from Tracy today. Can you go into more detail or direct me to the resource on the parameters for risk factors? Example, high BMI, or which dynamic balance tool are you using? The Y balance test.
Which one of you guys want to take that one?
Sure, I can take it. Everything on that list has been vetted in the research, and we've got references for those, so we're happy to share that. So that would take you to the study or two or three. Or BMI, there's multiple studies that have done a prospective research study to show that having high BMI, independent of anything else, is a risk factor. So we've vetted those, and they're in the research. We have references for those, and we're welcome to share those. We're certainly not hiding those, and that's the process. When we say dynamic balance, the tool that we utilize in all of our studies has been the Y balance test, and there's so many different data points you glean from the YBT. Asymmetry, how do you do against your population? How do you do at the limits of stability? It's an upper body and a lower body test. Having said that, there are other balance tests out there as well, but we found that to be the best. So we are talking about the Y balance test in that case. And there's multiple systematic reviews that you can read that can share or that can summarize the research with the YBT. So a systematic review takes multiple studies, goes through an objective process to give you a sense of sort of what's the summary of this tool with 20 or 30 or 40 studies. So those are the kind of levels of evidence or tools or resources that we're pulling from when we put something like that up on the screen. We're quite comfortable with those.
And one comment I'll make, and again, make sure I'm understanding it too, is when person asking the question says parameters, I think that may be leading to how the test was done or what the test was. And I think that goes back to what Kyle said at the end is reliability. So choosing reliable tests to make sure the parameters are already established on what's a low cut point, so to speak.
All right. And next, curious about the perceived recovery. Can you define what it means and how it's measured?
I'll let Phil take that.
Yeah, I'll be happy to take that. So it's called the SANE score, and it's been used somewhat in research, and we kind of think of perceived recovery as like a daily or an acute perceived recovery. That's not what we're talking about. We're talking about after an injury. It's basically a 0 to 100 scale. Just any Likert scale that you've used is on a 0 to 100% scale. 0 is I'm not recovered at all from my injury, to 100% I'm completely recovered and have no problems at all. What do you feel? What percentage do you feel? And there's actually not gradations in between as far as other anchor definitions. It's just those two spectrums, and that came out. You need to be above 92.5%, which really it's important to understand that 92.5%. I mean, that's really saying you're pretty darn recovered, right? I mean, it's not saying you're perfect, but that's basically saying you've got to be pretty close to 100. And for all those different markers, if you look at all the different discharge criteria checklists that we have, whether it's upper body, lower body, or spine, all those criteria are in there, and those are all based on the research, like Kyle said.
All right, now sticking with definitions, what is defined as low in low cardiovascular fitness?
Yeah, good question. Most of those data that we look at come from the military studies, and they typically use a standardized part of their testing. I think in most branches, it's a 1.5 mile run, might be a 2 mile run in some. I saw new things coming out in another branch that they're changing a little bit. So it's cut scores based on who got hurt relative to their performance against their peers. So it's population based. So that's most of my knowledge with it from military. Phil, I don't know if you've got a little bit more in sport, but I know musculoskeletal health in general population, military, it's usually a 1.5 mile run and how you do against your peers.
Yeah, 1.5 mile or 2 mile run. I think in our particular studies, I think it was somewhere around 15-30 2 mile run that you needed to be able to get at, kind of that 8-minute mile. Now recognize that's a population. Actually, it's kind of a neat population in that it is some frontline soldiers that we're testing, but it was also those people who support frontline soldiers, like your mechanics and cooks and things like that, as well as office workers. So people who are supporting from a logistical standpoint, maybe not be having a physical job, but having a desk job. Those risk factors apply to all of those, because I sometimes want to caution, sometimes when we say military, my understanding of what military meant, I always thought, I'm thinking like Navy SEALs, Army Rangers, and frontline people, but the military is pretty much a good slice of the general population.
Yeah, one thing I'll add right there, and you guys, correct me if I'm wrong, but when you do the research you're talking about, and let's use the cardiovascular, you're not going into the research saying they've got to achieve this. Basically, what's happening is the research and statistics are dictating what that cut point is. Is that correct?
That's correct. Yeah. So we basically do all of these tests in the military. The nice thing is all of these tests are already done as a standard procedure annually. So we didn't actually have to test them again because it's reported in their record. We did all the other tests, all the function movement screen and hop testing and 75% body weight carry, and all of those were done. And then we followed the person out, and those cutoffs were then seen based on who got injured, not based on, okay, let's just demand that someone is at that. And remember, it's, again, I don't want to keep beating this drum, but it is multiple risk factors. Let's say you have a 18-minute 2 mile time. That doesn't mean you're going to get hurt. But if you have an 18-minute 2-mile time plus ankle dorsiflexion restrictions, plus a higher BMI and poor balance, well, now we're starting to really worry there.
All right. And as an ex-fitness professional myself, I understand this question. You mentioned the role that rehabilitation providers play in reducing injuries. I'm a personal trainer. Do you have any advice for fitness professionals to reduce injuries?
I'll be happy to take this one. Yeah,
Go ahead, Phil. We're chomping at the bit on that one.
Yeah, absolutely. I'm all ready for this because I really believe that yes, rehabilitation professionals have a place to do it, but I will tell you right now in the rehabilitation profession, we are not doing a good job of testing risk factors at discharge or at the end of rehabilitation. And fitness professionals, if they can do the screening where they're doing the functional movement screen, the Y balance test, and looking at these risk factors, I think they can actually have as great or greater impact because frequently insurance providers don't pay for someone to go to extended protracted rehabilitation. They're going to be in the fitness realm, and again, just about everybody sustains an injury at some point in time, and it's really that is the risk factors that the fitness professional can screen for is, hey, let's do these 7 movements, see if they have pain with any of them. How is your hydration status? How are you doing with that? Measuring BMI. The cool thing is these all become biomarkers to show improvement maybe before the scale shows improvement, right? So I want to see, hey, gosh, I can feel better is, I remember one of my residents told me, who likes the Y balance test the most? I'm like, oh yeah, now you're just sucking up. But he said, the geriatric population in fitness, they like the Y balance test the most. And I said, really, what are you talking about? He said, yeah, because they come into me and I test them and they can't even reach behind them to do one of the directions at all, like 0, no reach at all. I work with them for 3 or 4 weeks and they're able to do it. And you wouldn't believe the smile that comes across their face. So it's about that testing. It identifies a risk factor, but just as important, I think it can really give a person, a sense of accomplishment and achievement.
Yeah, one comment I'll make on that, Phil, is I think the misconception again is that if you score low or you got pain, you got to immediately refer them out. But I think part of what we've got to realize, talking specific to the fitness world, we laid out the risk factors and you're already checking a lot of those things as it relates to, hopefully you are, behaviors and lifestyles and hydration, add the movement piece into the mix and just stack them up. Again, and the last thing I'll say is align yourself with a good medical provider. Don't hesitate to refer that person to someone that you have a relationship with. Don't just arbitrarily say you need to go see a physical therapist or a chiropractor. You need to communicate, and I think, in my opinion, if you're the first line on a lot of this situation, that kind of was what Phil was alluding to. Manage the client, manage your clients a little bit better, and understand that, if they've got pain and you start stacking up 6 to 7 to 8 risk factors, your outcomes for that person is not going to be that great unless you get some help. So don't be hesitant to think that you're not going to get them back. They're not going to be in therapy for weeks and weeks. It may only need just one of those once-overs. Hey, they're okay. Just watch out for this or that. So don't be too worried about that part of it. But create that relationship is the other point. The point I want to make.
Yeah, I've got to add on that because it's one of those things. You should be working together with a rehabilitation provider. The best fitness professionals, we work together and probably should be seeing simultaneously rehab and fitness because they really go hand in hand. Now, if it's a week or 2 that someone maybe needs off, yes, that's fine. But really, that rehab provider, if you've got that relationship, should just be telling you, hey, avoid this, this, and this. And most fitness professionals love that advice and heed that advice, and the patient or client wins.
All right, this is our last question of the day, and this person wants to know, where can I find the screening questions or tools they have referred to, such as sleep, nutrition, hydration, behavioral health, etc.?
Yeah, I'll take that. It's a great question. We're in the process of developing a system that will help you with that. It's coming out soon. So sort of sit tight and just keep an eye on your FMS email, and we'll get you that information soon. So we've got some tools coming your way to help with that.
And just a shameless plug, and I'll do this so Phil doesn't, is the Move to Perform algorithm that we have is definitely going to put you in those categories that we mentioned based off the research. So there are some things there, but as far as sleep, nutrition, the things that we're working on behind the scenes, yes, but those things are out there. So, there's certainly sleep questionnaires you can find, certainly nutrition questionnaires that you can find, behavioral health. So there's a lot of those tools out there. The only thing I'll add, and you guys, correct me if I'm wrong or back me up on this, make sure they are based on evidence. Don't just come to a website or social media and just pull something. Make sure that, they have references, there are some stuff, and I think we can probably direct you as well if you contact us. But yeah, make sure that whatever questionnaire you choose, and there are plenty of them out there, it is based off of evidence.
Yeah, I just add to that, it is very challenging if you don't have a background in research to go find a questionnaire, vet it for its reliability, validity, and what it's actually measuring. That's challenging. You don't have the training to do that. It's not your fault. That's why we can help with that and curate some of that information for you. And that's why we're doing the things we do. If you're working with general population near discharge, the move to perform algorithms, great. But if you're working with sort of Lee Burton, it's probably not exactly what you need. And as I said, we got new tools coming your way. So you can get lost out there quickly just because you don't have the training. We do, and that's what we're here for.
Well, I'll say just a couple of things. Again, thank you all for sticking around with us for this last hour or so. I want to thank Dr. Kiesel and Dr. Plisky so much for their expertise and everything they've done for functional movement systems. So I'll turn it over to Ashley for some final thoughts.
Thank you so much for joining us today. And we do have some links and other important pieces of information in that chat as well as in the description. If you like today's conversation and you are an FMS Pro member, please be sure to check out our discussion groups. They happen almost weekly and they're hosted by our very own Michelle Desser and other FMS experts. We go through a lot of this information there as well. And we have the Movement Podcast is premiering this Thursday. We have Kelly Start as the guest this week, opening our season 4 premiere. So we have that to check out. We also recommend that if you have any questions about the FMS, the SFMA, YBT, or even Move to Perform, you can check out functionalmovement.com. All right. As always, we want you to remember to move well and then move often.